Good afternoon. Very glad to have the chance to interview you for the AANS archives.
Thank you. I'm glad to be here.
As you know, they're asking distinguished neurosurgeons in this country to tell a little bit about themselves, and so I'm going to try to get you to tell us a little bit about your own development, what led you to become a neurosurgeon, how it all evolved, and how you look at neurosurgery in the future.
Fine.
Let's start off. Tell us a little bit about how you came to enter neurosurgery.
Well, I think my father was probably the most influential factor in that. I first made rounds with him when I was 14.
Where was that?
At the Good Samaritan Hospital in Los Angeles.
Uh-huh.
And
Did he make you put on a white coat?
No, but I watched him do an operation. I watched him do a pituitary tumor, as a matter of fact.
How old were you when you saw the first pituitary?
When I was 16.
16?
Mm-hmm.
And you decided that's what you wanted to do?
Well, actually, I decided I wanted to be a fighter pilot in World War II, but the Navy decided I should become a neurosurgeon, along with my father.
I see. Now, did your father actually tell you it was a good idea for you to go into neurosurgery? Did he encourage you or discourage you?
Well, I wouldn't say either, Rick. I think he just thought medicine was a wonderful profession, and he wouldn't object to my going into it if I thought I would enjoy it.
Uh-huh. Do you, I guess you see him in a sense as a role model in your formative years?
Absolutely, yes.
Did you talk neurosurgery at the dinner table, or did you talk neurosurgery when you went vacationing, or?
I knew the cranial nerves by the time I was 14.
Did you?
Yes, I did. I was taught the cranial nerves. I remember on a visit out to Whittier when he was seeing a man who had gone blind from drinking wood alcohol. And I was required to learn those cranial nerves.
On the way?
On the way there, yes.
Okay. And did he suggest where you should go and study neurosurgery, or where you should go to college to prepare yourself?
All right, he thought about neurosurgery. He thought I should go to Ann Arbor. Because in those days, with Max Pete there, and with Fred Collard there, he thought this was the best surgical training center in the United States. This was 1948 when I finished medical school.
Your father had trained where?
Well, he'd gone to Johns Hopkins, and he graduated from there in 1912 under Bill Halstead, Dr. William Halstead. And he was an intern under Dr. Halstead. Then he went to John B. Murphy in Chicago. And then Cushing, Dr. Harvey Cushing, called him to come to Boston, to the Peter Ben Brigham Hospital.
So you're sort of, in a manner of speaking, a grandchild of, a neurosurgical grandchild of Harvey Cushing's.
That's right. As a matter of fact, I have some books that were given by Osler to Harvey Cushing, to my father, and then to me, and now on to my son Richard, who's a doctor.
Great. So your father encouraged you to go to Michigan, and can you tell us a little bit about Dr. Pete and his influence on you?
Well, I don't know if you are aware of this, Rick, but he was a great ornithologist as well as being a great neurosurgeon. No. Oh, yes. And he has a fabulous collection of birds that he left at the university. He had great surgical skills. For example, he could do a Spiller-Fraser operation routinely in 20 minutes. And one time he was clocked at doing it at 12 minutes, skin to skin. So he had this enormous technical skill as well as surgical judgment. My father thought that I should be exposed to this type of talent.
Tell me a little bit more about your father. I knew your father, as you know, and still have memories of him making rounds with us after he had retired from his chairmanship at USC, but he used to come over to the Wadsworth Hospital and would be very interested in seeing patients, and I remember very well that he said something about the significance of the superficial abdominal reflexes in patients. But other than the fact that he was your father and that he served as a role model, tell us a little bit about the qualities, if you can see them objectively as the son, that sort of influenced you and influence you to this day in how you look at neurosurgery?
Well, when he retired, I asked him to summarize his medical surgical career, specifically neurosurgical career, with one word, And he said, well, the word is service. And that was a word he lived by. He lived by that word. And he taught me the importance of that word. And he said, if you can't serve in this profession, then you shouldn't be in the profession. And he felt that way about the residency training programs, about the medical students, about the patients, about all of his colleagues. He felt very strongly about that.
And when your father made the recommendation that you go to Michigan, did he know Dr. Koller or Dr. Pete himself?
That's an interesting story. When Dr. Cushing asked my father to stay on as his assistant, my father respectfully declined and went to Los Angeles. And Los Angeles in those days, of course, was only a town of 50,000 people. But he had known Dr. Frederick Koller in Boston at the Peter Van Brigham Hospital. And he had gone to Los Angeles. So my father didn't follow Dr. Koller there, but when he arrived, Dr. Koller was there, and he and Dr. Koller went into practice together.
I see.
They were both trained in general surgery. Of course, my father had been trained by Dr. Halstead and by Dr. Murphy. And so they both did general surgery together while my father was trying to initiate this new subspecialty of neurosurgery.
And then Dr. Koller went off to Michigan
right,
after
then
that.
Dr. Koller was called back to Michigan, and I think my father might have ended up in Michigan if it hadn't been for Dr. Pete being there already.
Yes. Well, tell us a little bit what you recall about Dr. Koller as a man. Did you interact much with him?
Well, Dr. Koller believed in the following concept of medicine as an example. He believed you're first a physician, then a surgeon, then a specialist. And he resented enormously any resident calling a referring physician the, quote, local doctor. I remember one time when a resident got up and said, Dr. Koller, Mrs. Jones has this gallbladder problem, and she was referred by the local doctor. And he said, doctor, you come over here. I want you to meet my personal friend of 30 years. He is not the local doctor. He is the patient's personal physician. And he felt very strongly that.
Yes. And he emphasized a broad medical background as well for his
yes,
surgical trainees. Well, I saw a little bit of that in one of his trainees, as you know, Dr. Buxton.
Sure.
And what about Dr. Pete as a person? I mean, I've heard you speak before of his surgical skill, and particularly with reference to the Spiller-Fraser procedure, but how did he come across as an individual?
Well, he was a very strong person, a very dynamic person. I mean, I don't think you'd like to argue with Dr. Pete. He was a fairly large person, and he had strong opinions. And of course, his opinions were always the correct opinions.
Yes.
But he would listen to your point of view. For example, one night I came down to his office and I told him that I did not think this patient was a suitable candidate for a splanchnosectomy because of certain problems that I had uncovered in the workup. And he listened to me and went over the patient with me and said, you're right, we'll postpone this operation. So he would listen to the house officers.
Now, did Dr. Pete die during the course of your residency or right afterwards?
Well, he died right during the course of it. He died on March 25th, 1949. He died of a heart attack. It occurred during an operation. He walked to the heart station and then was taken upstairs on a gurney. He died there in the private pavilion area of the hospital. As the doctor, one of the house officers was trying to start an IV, and he said, don't worry, son, everything is going to be fine, and died.
Amazing. I had no idea that he was ill, that he had coronary
Well, I think he knew. He was afraid of retirement, and he was afraid of getting old. I think he'd rather die at 65 as an active surgeon than to linger on.
I thought he had been younger when he died. He was 65 at the time of his death. And then Dr. Kahn took his place while you were there.
Right.
And so you had contact with...
I worked with Dr. Kahn for 2 years, and then I worked with Dr. Elizabeth Crosby and got my PhD in neuroanatomy from her, having had my master's degree in surgery from Dr. Koller.
I see. Now, Dr. Crosby did some work in neuroanatomy with you, or rather you with her.
It was more like my being with her. She was a marvelous person, and of course around the campus she was known as Ma Crosby. The medical students were devoted to her, and she felt that if you did not get a good grade in neuroanatomy, that she was at fault, not the student. And she felt very much that way. She also thought that when she came back, she would like to be an MD. So the
In her
University
next
of Michigan,
incarnation?
right, exactly. The University of Michigan gave her an
Really?
honorary
I didn't know that.
MD
No,
degree.
that's great. Yeah.
But she led me by the hand through this year of mine when I did experimental work on the primate cerebellum. And although I would like to give myself credit for discovering many of the efferent and afferent pathways that had yet to be described, it was really Dr. Crosby who said, "No, Dr. Rand, don't you think that that's a new pathway?" So I would trace it out, and lo and behold, it would be a new pathway. So she guided me to the new pathways.
She'd look at the slides under the microscope with you and query you, and that's
Right.
how it came about. And am I correct that it was as an outgrowth of your experience with Dr. Crosby that you first wrote up the procedure of Lissau tractolysis? Is that correct?
Yes.
Yeah.
I became interested in neuroanatomy, of course. And it seemed to me that Lissau tractolysis would be an ideal technique to relieve local pain in the arm. And I did a number of those experiments with a friend of mine, Dr. Ernie Pinka, when we were in the service during during the Korean affair. And it's now, I think, pretty widely used as called, I think, the dorsal column lesion.
When did you do your first patient Lissau tractolysis?
At
in
the
Michigan?
Veterans Hospital, no?
No, at the Veterans Hospital.
And it went rather nicely. The poor man had terrible brachial plexus pain. And we made a series of lesions, and he was completely relieved of his pain. And yet he still had touch sensation in his hand.
No human subject protection committee?
No.
Oh, all right.
No human subject protection committee. But I didn't think it was an unwise
Did you have to
operation.
tell him in those days? This would have been when, in the early 50s?
1956.
Did you have to tell him that this was a new procedure that you had developed, or and that you were doing your first case, or was this sort of a situation that you just said, "We're going to do an operation for your pain, sir"?
No, I told him. I thought he should know the details. I don't think he really understood what Lissau's tract was, but I was very pleased to tell him all about it.
Okay. Well, so then when you finished all this, before you came to Los Angeles, if I recall correctly, there was another significant personal event in your life that occurred while you were in Michigan.
Oh, yes, indeed. I met Helen.
How did you meet her?
My wife. Well, I first saw her at a party, and she was there in a long gray gown with a cigarette and a cigarette holder and having a cocktail and speaking Russian to some international friends of hers. And I became very intrigued with this young lady and thought, this is the kind of lady that would make a wonderful wife. And so I pursued her, and we were married in December of 1949.
That was how many weeks after you had met her, or how many months?
Well, I asked her to marry me within 2 months of the first engagement that I saw her.
So early evidence of goal orientation.
Right.
All right. And I
should add that we have 2 sons.
You have 2 sons.
We have Carl Wheeler Rand II, and we have Richard Pierce Rand.
And one of your sons is a physician, right?
Richard is, yes.
Richard.
And
What is he doing now?
He's a plastic surgeon at the University of Washington, and Carl is a science engineer with IBM.
So you have a third-generation academic surgeon in your family,
Right.
and a modern computer analyst. Is that right?
Absolutely, right.
And then you headed back for Los Angeles was the idea that you were going to work with your father when you came back?
Well, as a matter of fact, yes. My father and his partner, Henry Cuney, had moved to a new office to accommodate my arrival, which was in 1952, and I was there for a year. And then I was invited to join UCLA School of Medicine. And when I joined the school, I think there were only about 15 surgeons in the entire department. Dr. Lallmeyer at the time was in the Air Force, serving in the Air Force, and Dr. Pressman was in charge.
I see. And so after a year of private practice, you joined the faculty.
Right.
And jumping ahead a little bit, I think it's fair to say that you, how many years were you on the UCLA faculty before you retired?
35, 36 years.
35 or 36 years. So it's not surprising that you would have had a profound impact on the development of the UCLA neurosurgery training program and everything that went on there. Tell us a little bit about what, looking back, you think were your major accomplishments during the time that you were there.
Well, I think, you know, Rick, that my research was well, should we say, it was toward the practical side. I tried to do, like with Lissar tractolysis, I tried to do something that would be beneficial to the patient. And then I became involved in cryosurgery, and we did the cryohypophysectomy and pituitary tumors, again, directed at the patient, trying to avoid radiation. And we had an 85 to 95% cure rate on the acromegalic patients.
Well, that's interesting. You know, my image of you at UCLA was always that you would come up with some technology that had not been applied to neurosurgery before, and somewhere along the line you saw a possibility that wasn't recognized by others, at least not at the time that you saw it. And cryosurgery seems to me is one of these. How did you happen to think about the use of cryosurgery in neurosurgical procedures?
Well, actually, it was introduced to me by a classmate of mine at Ann Arbor, Dr. John Titus. He had done work in Seattle, and he developed some cryoprobes that were used in dogs to destroy the pituitary and make lesions in the brain. And that was then developed by Arnold Lee and Irving Cooper, as well as some others, including myself. And it was a wonderful experience. I see now that it may be coming back to some extent. I noticed in one of the posters at this meeting today.
And there were other technologies that you also applied. I mean, things that you presumably heard about from colleagues in engineering fields, your use of ferromagnetic consolidation of blood clots comes to mind. Tell us a little about how that started.
I'd like to tell you a little bit about that. When I was with Talleyrand in Paris in 1960, I observed him doing an angiogram with this Talleyrand frame on, and you could see immediately the potential of stereotactic vascular surgery. And I thought, well, if I could just figure out a way to occlude an aneurysm, that would be marvelous. So when I came back, I ran across John Oxney, and John and I talked about the concept of stereotactic angiography and aneurysm treatments, coming up with the idea of putting a magnet down against the aneurysm. And in the early days, we were going to put the iron directly into the carotid artery. And we did 2 cases, trying to capture the iron into the aneurysm. And these are particles of 5 micron in size. And one patient had a slight reaction, and therefore we abandoned that technique and decided the best way to do it was to drill a hole in this permanent magnet and pass a needle into the aneurysm and inject the iron, which was suspended in albumin, into the aneurysm, and then let it collect in the aneurysm, leave the magnet in place for 2 or 3 days, and then take the magnet out. And we had a great success on numbers of patients, especially in the anterior communicating artery.
You'd send the patient back to the ward with the magnet?
Yeah, with the magnet
sticking out of his head?
Well, no, not sticking out actually, but fixed to the skull. The magnet was made in sections, so you could make the size a proper. Once in a while, it did come out just a bit, but ordinarily we were able to close the scalp over it.
And then later on, you developed that further. Didn't you also develop a stronger magnet?
Well, I became intrigued with the idea of using an external magnet. So I went to Stanford to the linear accelerator, the Stanford linear accelerator they have, and I met a Steve St. Laurent. He's a PhD in cryogenics and magnet. And together we made a superconducting magnet. And this magnet had 80,000 Gauss full. I remember one time I was in Stanford and I was walking in front of the magnet with a white jacket on and a wrench in my pocket, and it pulled me to the magnet. And he said to me, Bob, now look, don't do that again. You're going to ruin our magnet. But it worked. We did 6 cases of aneurysms using non-magnetic needles and injecting the iron. I got a letter not long ago from a patient who was treated over 15 years ago that way. And then I got interested in injecting the iron in kidneys for tumors, for example. And then I got interested in the idea of heating the iron particles, and I developed a coil to do that with the scientist at Jet Propulsion Laboratory.
You went to them and you said, tell me.
I went to them in my naive way and said, look, we need to heat up this iron and using the concept of hysteresis. And they said, well, we can do that. And they made a coil, and it turned out that you needed 500 kilowatts of power to run the coil, which was slightly too large. So then I came up with the idea of putting a Litz wire inside, not the copper tubing, but a plastic tubing. And that cut the power down from 500 kilowatts of power to 25 kilowatts of power. It made it practical.
What kind of a wire?
A Litz wire.
What is that?
Well, it's a braided copper wire, and it comes in different sizes, and you can reduce the resistance to the passage of current with a Litz wire and cool it in this system, so that we had rather good results.
Now, if I understand correctly, you're still working somehow in an extension of all this today, is that right?
Yes, I've given that coil to Loma Linda School of Medicine, and they're working on it with Dr. Ross 80 at that school.
And you are now also at Loma Linda?
Yes, I am a professor of neurosurgery at Loma Linda.
And aren't you also still using some kind of ferromagnetic technology in some work that you're currently doing?
Well, I was always interested in aneurysms, and you and I worked on many aneurysms together with the microscope, and then I became very intrigued when Severenko came up with the idea of using microballoons, and I had the opportunity of meeting him about 9 years ago when I was in Russia. But the problem with those balloons, as I saw it, and talking with Grant Hashima and others, is that you have a 35% failure rate. I mean, you either rupture the aneurysm, or the aneurysm doesn't clot, or the balloon migrates. So I thought, well, let's put a thrombogenic surface on it. And because of the work I'd done with John Oxney, the idea of putting particles like iron on the surface seemed logical, and we've done some experiments, and it's worked out very nicely. You can develop, so we have now developed the thrombogenic microballoon.
That's great. There were some other things, though, that you did, as I recall. One of the really strong points in the training program at UCLA was the resident's introduction to the use of the surgical operating microscope. How did you become involved in, or how did you first think about applying the surgical microscope to neurosurgical procedures? You're certainly
I got introduced to it really by Dr. Ted Kersey, who was introduced to it by Dr. Bill House. And those were in the early days of the 60s, 1961, 62. And I became intrigued with the idea of using the microscope in neurosurgery, along with Dr. Kersey. And one of my earliest experiences was trying to find and save the facial nerve in a lady who had a generous acoustic tumor. And I never did find the nerve. We did take the tumor out. She had a palsy. She unfortunately died because of swelling of the cerebellum, and I became very concerned about that and thought, well, there must be a better way of doing these operations. And so I set about working out the technique of the suboccipital transmetal approach with Ted Kersey.
So in essence, the fact that you had this unfortunate experience with the patient early on somehow stimulated you to try to develop a better technique for dealing with acoustics. And you and Dr. Kersey worked on this. Now, Dr. Kersey was at this time at UCLA as well?
Well, he was at UCLA for a year when I was in the service during the Korean affair. Then he went to USC, where he was the chief at USC School of Medicine and Neurosurgery. So he was at USC and I was at UCLA when we were doing this as a joint venture, so to speak. And we did our first cases, let me see, in 1964, I believe. We did 3 cases consecutively. They were given to us by Dr. Victor Goodhill, a very famous otologist, who was there in the operating room during those cases. We saved the facial nerve in each case. We did a total removal. It was quite a pleasurable experience. And I think it really just changed a lot of the attitudes of surgeons toward acoustic operations.
And you just had the drill available at that time too?
Well, we didn't have the high-powered drill. We were using a dental drill.
I see.
It was a low-powered dental drill. And you had to be careful that the drill was going in the correct direction, because you didn't want it to skid into the brainstem. So you'd reverse the drill. But it was a worthwhile technique.
And monopolar cautery, or did you already have
We had
the
bipolar cautery, but not as
bipolar?
exquisite as it is today.
And in the course of time, do you have any idea how many acoustic tumors you operated on?
Well, we did several hundred. Fortunately, I operated on several hundred with Ted Kersey, which was a lot of fun. And it was important because one person could work while the other person would take a little bit of a rest and try to develop a technique. Our results were quite good.
Did you preserve hearing in any of these early cases as well as the facial nerve?
Not as well as we had hoped, but I think that was the beginning. And now people like Peter Janetta and Sammy, Professor Sammy, have preserved hearing in about 50% of patients where the hearing has been useful prior to operations.
Yes. Well, that's quite remarkable, considering what you were working with in those days, too.
And we weren't monitoring, we weren't able to monitor the cochlear nerve at the time, and all those things have now changed for the benefit of the patient, of course.
And then, of course, you also used the microscope for aneurysm surgery, and what else did you initiate? Do you have any other
Well,
things
I think that we were the first to use the microscope for basilar artery aneurysms. And we found that it became apparent when we began to work with aneurysms that the reason that people were dying was you were clipping the perforating vessels. And I think that's one contribution we made, was the realization that you must avoid these perforating vessels. And so that our mortality at UCLA went from 25% on the anterior communicating arteries to less than 5% by observing these principles.
What kind of clips were you using in those days?
Basically high-fits clips.
High-fits clips?
And even some just simple closing clips where we didn't have the high-fits clips.
And then
we even used ligatures. I mean, the first basilar artery aneurysm I did, we tied it on to get the tie around the neck without getting the perforating vessels.
Did you also do some muslin wraps? And
well, we did some of those. I think they were helpful too, where you couldn't really dissect out the aneurysm. At least we felt we couldn't in some of those cases in the early days.
You think that today's neurosurgeons might be more aggressive about manipulating the aneurysm itself and getting around it than...
Oh, I think they are.
Yeah.
And I think that's to the patient's advantage. I mean, for example, Dr. John Fox is quite skilled, as is Dr. Yasekil in doing this, and of course Dr. Charles Drake.
Yes.
And I think these people have learned these techniques to save the patients from disaster. You may recall, I don't know if you ever knew this, but Charles Drake tried to do some basilar artery aneurysms, and I think his mortality prior to the microscope was 95%. I mean, it's a very large percentage, and it wasn't until the microscope was introduced that these kind of aneurysms could be effectively treated.
Well, I recall trying to clip an aneurysm with a pool clip, and I shuddered to think back about some of those early experiences. You, during the time that you were at UCLA, you took some sabbatical trips abroad that got you started in new directions as well. Tell us about
Well, I took one sabbatical. In 1960, I went to Paris, and I stayed with John Talarak at St. Anne Hospital, and I learned some very interesting things from Dr. Talarak. And when Dr. Talarak had started out as a psychiatrist and then became a neurosurgeon, yes. And the first day I walked in, there was a patient on the table with a frame on and a drill, actually a cannula going right through the frontal sinus, right to the basilar ganglia. And he was putting in an yttrium sphere into the globus pallidus in a patient with Parkinson's disease. And I was alarmed when I saw this going right through the frontal sinus, but in actual fact it was the quickest way to get to the globus pallidus and one of the safest ways. And the patient incidentally had a very good result.
So how long did you spend there, a year?
It was nearly a year. And during that time I took some side trips. I visited Riekert in Freiburg and Munninger, who was there. I visited Lars Leksell, Stockholm, and of course Guillaume, who was in Paris.
And then when you came back to UCLA, you started using a Tallerac frame?
Well, I started the depth electrode program, the epilepsy program at UCLA. I think I was one of the first to use chronic depth electrodes in epilepsy. Tallerac up to that time had only used acute recordings. And when I came back, we began to use chronic recordings. So they would leave the electrodes in for as long as 2 or 3 weeks.
I see. And then you did the temporal lobectomies at that time. But you also used the Tallerac frame, if I recall correctly, for some basal ganglion work in Parkinsonian patients.
Yes, yes. And we would combine that with an arc system we developed that was useful in cryothalamotomy, the technique that Irving Cooper had started. We did a lot of those. We designed an instrument, a stereotactic instrument, similar to Tallerac's for hypophysectomy, because I couldn't get his instrument. It was impossible to get it out of France. So I made my own with Trent Wells, and we did some cases, did quite a few cases.
You did quite a few cryohypophysectomies. And you also did quite a few cryothalamotomies, didn't you?
Oh, I'd say in early 2000.
Nearly 2000.
Right. And the results were very good. You know, I worked with Charlie Markham, the medical neurologist, and he reviewed our cases, and we had very good results.
That's remarkable. Is anyone still doing that procedure today?
Well, I've done a few of those. I still think it's a valuable procedure. Of course, one thing I learned from Lars Leksell was the idea of radiosurgery. And I was always intrigued with his work. So when he developed his first gamma knife, I was there to watch it work, and he trained me how to work. And then when they closed the private hospital in Stockholm, I managed to get that instrument to UCLA as a gift in 1979.
Now, am I correct that when Professor Leksell first introduced the gamma knife, as it's known today, people were very skeptical that this was anything of practical use in neurosurgery?
Indeed. They thought he was a heretic. I mean, they thought that he should not be allowed to do this. I mean, as a matter of fact, he told me once that he almost lost his position at the Karolinska because of this.
Is that right? And again, I mean, I come back to what I said before. Somewhere along the line, you saw in this instrument that there was some future application to neurosurgery that many people who walked by that same demonstration didn't see. Is that correct?
No, I don't think they understood it. I don't think they understood the concept of bloodless brain surgery. I mean, it would alarm them to think that you couldn't use the knife and use the scalpel and do an open operation. I mean, the idea of using it to treat tumors or functional neurosurgery was not in their thinking.
What was Dr. Leksell like as a person?
Well, he was a wonderful man. I first met him in September of 1960, and I sat outside of his office for about 8 hours. And finally he came out in the late afternoon and introduced himself and had me come in, and we taught him. He handed me a manuscript, and he said, "This is a manuscript of my technique and a book in English. I'd like you to take it back to the hotel and read it and correct it." So I did. I spent most of the night doing that. And I brought it back the next day, and we became very good friends after that.
And it was through your friendship and that that original prototype gamma knife was brought to UCLA.
Right. And we did some interesting cases. For example, we did about 15 cases, pain and several acoustic tumors, several vascular malformations. We did one lady who had 2 operations at UCLA for a vascular malformation coming off the anterior cerebral artery, had been untreated, and we did the gamma knife. She called me just the other day to indicate that she just had a child.
Is that right?
Yeah.
That's great. Now, you're currently working with a, what, 2nd or 3rd generation gamma knife?
I think it's about the 3rd. The 2nd generation was built by Scantronics, and there's 2 of those, one in England and one in Buenos Aires. And the 3rd generation is very similar to the one at UCLA. They've changed the helmets a bit, and they've changed they now have 4 helmets instead of the 2 that we had, and it's a wonderful instrument, and it's now at the Good Samaritan Hospital in Los Angeles.
Are you still developing new techniques in relation to that?
Well, I would like to come back, for example, and go back to functional neurosurgery. I mean, now that we have MRI imaging and high resolution, there's no reason you couldn't make appropriate lesions back in the thalamus and other areas for movement disorders and for other reasons.
Sure.
So I think it should be redeveloped in that area. That's the way Lexell first had tried to develop it. It was in functional neurosurgery.
Functional neurosurgery.
So I think we should go back to that. I think it's a wonderful opportunity to go back to that.
That's great. What else did you, can you think of in way of things that you did in all those 36 years at UCLA?
Well, I enjoyed training residents. I think we've had a very good group of residents come from the UCLA program. My role, I think, was trying to help them learn surgical technique. I believe, and that was the way I was trained at Ann Arbor, I believe that to be a master surgeon, you have to be a good technician, or even an excellent technician. And I think that patients go to doctors, specifically surgeons, who are skilled in doing operations. And
true.
I've always tried to help the residents become very skilled in any operation that they're trying to do.
Could you, when you operated with a resident, was it easy for you to tell whether that person would make it in the world of neurosurgery or not? And how much time did it take you to make that judgment?
Well, I think you know, you've trained a lot of residents yourself, and I think that you know, you have a feeling as to whether or not he knows how to use the instruments when you first watch him make a skin incision. And some of them are more easily trained than others. Some of them will never have the high skill, for example, that Max Pete had, or that others have had. But I think I don't know of an incompetent resident that we've trained at UCLA. I think they've all had good skills. How
did you decide? I mean, you were, as you say, the person that people came to because of your reputation and skill. How did you decide what a resident could do when you were training him in the course of a surgical procedure?
Well, I feel that the patient has to be served first. I thought that if the patient could be served by the resident in putting a clip on an aneurysm, for example, that the resident should do that, because he needs to know how to do that. And he's going out into the world, he needs to go out and help patients, and he can only do that by experience. But I on a number of occasions, would ask him to give me back the instruments and finish the operation myself. I felt that I had to do that. Now, in my own private patients, if he could put the clip on, I'd let him take the first chance on that. But he had to have a lot of skill by that time, or I wouldn't let him do that.
Right. And, I mean, the recollection that I have is that you were quite open-minded to suggestions from the resident who might say, why don't you do this, or why don't you do that? How do you feel about that?
Well, my father had a philosophy that in order to stay young, you had to be with the young. And I think that's what's helped me. I think I still have some young ideas, and I think the young people have helped me. And I think that you have to be open to new ideas, because it's the young people who come along with the creative ideas that maybe you've become too narrow in your thinking, and they can open your mind again.
I'll have to tell you that one of my fond recollections is the day that I helped you do an acoustic, and when the tumor was gone, we looked at the two ends of the seventh nerve.
Oh, I remember that case.
And you were very upset, understandably, and somehow I said, well, why don't you just put a suture through that? And if I recall correctly, that lady regained seventh nerve function.
She did very nicely.
And you gave me a small check of $50, which was at that time 1/7 of my monthly salary, so it was a very significant addition to our income.
Well, and that of course has been done a lot since that time.
Yes.
I think Professor Sammy has gone on to really develop that technique. The concept was first developed by Professor Dott in Edinburgh, I believe. But I must confess, and I remember that case very well, it was very distressing to see the two ends of that facial nerve after that tedious dissection. But she did have a nice final result, yes.
Well, I think certainly the impact that you had on many of the residents who went through the UCLA program was quite strong, and many went on to leave their own mark in micro-neurosurgery in years to come. We've talked a lot about your accomplishments, and you've written a great deal in neurosurgical literature, and it always occurred to me that somewhere along in your early formative years you must have had some particular experience in writing and in expressing yourself verbally, something that isn't universally present today even in young academic neurosurgeons. Do you recall where this influence came from?
I think you're kind to say that. I went to Harvard as an undergraduate, and I was taking the usual English course, and I was told by one of the teaching instructors there that I would never be successful, that I was not able to write. So I decided that here again, you take an adversity and try to make it into something useful for your life. And it was at that point I decided I must learn how to write if I possibly could. I remember writing a paper one time with my father in 1952, and he said, well, he said, the idea is fine. He said, but it's very badly written. So why don't you rewrite it until it is properly written? So I must have rewritten it about 6 times.
So he was a bit of a schoolmaster.
Absolutely. He had his master's degree in English from Williams College.
I see.
And he wrote poetry and he wrote music, and he did not enjoy listening to bad English.
And you, in fact, you wrote a book together with him, didn't you?
Yes, we did.
What was the book on?
On intraspinal tumors in childhood. It took us 5 years to do that book. We worked, you know, almost every night and over the weekends.
Well, if he made you rewrite it so many times, I could imagine.
Well, I wrote the text, and I did all the literature search, and he worked on the cases because they were primarily his. He insisted I be the first author, as you can imagine.
Yes.
He did. And I learned a great deal of writing from that experience.
I have to tell you that one of my memories of seeing you in our Saturday morning conferences when we were planning surgery for the week ahead was that you would be listening with one ear and always writing with the other, so to speak. And that's sort of one of the examples of practicing writing, but that must have been more than just coincidence.
Well, I always carried, my father always had a pad of paper and a pencil with him. And that was because he'd get an inspiration for a poem and he wanted to write it down right away. For example, one day he was on his way to the county hospital and he saw a statue of Father Sarah, and he loved the missions. So he stopped and wrote the poem called Sandal Feet, right there, you know, 2 or 3 pages. So he always taught me to carry with me a pad of yellow paper and a pen, so that if I had an idea, I could write it down. Or if I wanted to write a paragraph on some subject, I'd write the paragraph. And I did a lot of that on Saturday morning, you're right.
So you wrote a lot of those many papers were conceived on Saturday mornings.
I wrote them on Saturday mornings, right.
And what about reading? Are you a very avid reader? A very quick reader?
Well, I read rather quickly, I think, and I read mostly scientific literature.
Let me stop off for a moment. What happened to your father's poetry? Was it ever published, or?
No, I think sadly it has not been published. I think it should be published. I've tried to encourage Helen, who's a good artist, as you know, to put his children's poems together, the poem on one side and a drawing on the other side. And she promises that she will do that.
That's a nice
idea. She was the one who typed up all of his poems.
Was she?
200 or 300 poems.
Oh, really? I didn't realize that he was...
I'll show them to you someday. Oh, you'll enjoy them.
Yeah, that'd be neat.
Sure.
Now, as far as you mentioned Helen, it brings me to the fact that you and she compete at golf quite actively,
you
don't you?
You shouldn't bring that up.
Well, tell us about your hobbies.
Well, I only have one hobby now, and it's golf, and of course that's a very difficult sport, as you know. But Helen and I were at Disneyland one time, and the boys were there, and it was at a meeting, I think, the California Medical Association, and perhaps I had an exhibit or something. And there was a putting green there, and Helen hit the ball rather swiftly beyond the hole. And I said to her, I said, now, darling, I said, this is a putting green, not a driving range. Well, she took this adverse comment, and she is now a better golfer than I am. Her handicap is lower than mine, And we do enjoy playing golf together on Saturday and Sunday afternoons.
That's great.
But I don't compete against her.
You don't compete against her, I see.
No, I do not.
How about your sons? Do they play golf too?
Rich is rather a good golfer. He got down to a 2-handicap golfing.
That's good.
Carl never enjoyed it, but Carl became a marine biologist. And Carl knows the name of every fish in the world. And we used to go scuba diving together. And I remember one time when Carl and I were diving off the Coronado Islands at 3 o'clock in the morning, doing some night diving. And I found that rather alarming. And I stayed next to him like a baby seal. I would remember the third dive that we had and how much joy I had when they saw the sun coming up.
Yes, I could imagine.
through the ocean, right? But he's gone on from that to teaching school and then on to a master's degree in business administration, and now with IBM.
Speaking of things that sounded scary, you just reminded me, if I recall correctly, you had a picture of a race boat in your office.
Yes, right. Yeah, our unlimited hydroplane.
Yes, and didn't you also do some flying?
I did that. Let me tell you just a moment about the boat. The reason I got interested in the boat was I was interested in seeing if you could turbocharge a V8, a V12 Allison engine. I didn't realize that they'd done some of that during the war. And I went to the person who did the turbocharging on the Indianapolis cars, and he got out his slide rule. The computers weren't available in those days, and he calculated that he could do that. So we raised the money and we built 2 engines, and we put them in this boat, which would go 180 miles an hour.
How many times?
Well, I drove it never on a race, but I drove it a few times, and I remember Richard telling me that you're not allowed to drive that boat over 40 miles an hour, Father.
I see.
And the boat idles at 40 miles an hour. I mean, the boat put out 3,000 horsepower at 3,000 RPM, and the ratio to the engine to the prop was 1 to 3, and you light that engine, you're going 40 miles an hour.
What happened? Did they put it in the Smithsonian, or where is it now?
No, it's retired.
It's retired.
They're now making newer and better boats. But it was a fun time in my life. That was the time I went to law school. I was going to law school at the same time I was racing boats and trying to do research.
Why did you go to law school?
I was entered into the University of Michigan Law School at the end of my 2nd year of training. And I was going to start law school there in September of 1949. Yes.
During your neurosurgical training?
No,
during your medical school.
I couldn't decide whether to go on in medicine or change. So I was admitted to University of Michigan Law School, and then I met Helen that spring, and then I couldn't go on to school any longer, and you have to earn a living, so I dropped that. But then I came back to it in 1969. I enjoyed going to law school. I don't practice law, but I enjoyed the education. I enjoy becoming educated.
Do you make use of it in any way in your thinking and your...
Well, yes, I think it helps me in understanding negligence and constitutional issues, and I enjoy knowing something about the law. I wouldn't consider myself, a superb law student, but I enjoy law. I think it's interesting.
Yeah. What about flying? You know, you gave flying up after...
Well, I'd wanted to fly during World War II. As I told you, I wanted to be a Navy fighter pilot. But everybody changed my mind on that, and I went to medical school instead. Then I picked up flying with Jack Cannon, who was a friend of mine. And you remember, he was the person who developed endarterectomy of the coronaries for occlusion back in the early 50s. And he and I used to go flying together. He had an airplane, and I had an airplane, and we used to go flying together. It was a lot of fun.
And you gave it up when?
Oh, I flew for about 5 years, and then I found that I was getting a little bit bored with it, and Helen wouldn't fly with me, and she wouldn't let the boys fly with me, which was very smart. I mean, very smart decision. So I gave it up, but I enjoyed flying. There's a certain freedom of flying.
Where'd you go? Where would you fly?
Oh, I'd fly to Santa Barbara and San Diego, and over to Catalina Island, and once in a while up to San Francisco.
Do you ever get lost?
Once, yes.
Once?
Thought I did the old trick about the railroad tracks. I found some railroad tracks and found my way back. But I enjoyed flying.
Oh, that's great. Well, getting back to neurosurgery, from the vantage point of someone who has spent a career, lifetime in neurosurgery and developed new things, how do you see the future of neurosurgery? Do you see technical directions in which neurosurgery is going to go, and practice directions in which neurosurgery is going to go?
Well, the one concept that's come along I think is very interesting is the concept of putting stereotactic and microsurgery together. And I think that's going to expand horizons in technical neurosurgery. And I'm very pleased to see that because I've enjoyed both areas,
yes.
Stereotactic surgery and neurosurgery. I think there's a limit to it, however, and therefore I've become interested in other areas. Three of them specifically. One is to continue on with the stereotactic radiosurgery. Now there's going to be, I think, an explosion in terms of using techniques of imaging and therapy. I mean, if, for example, if you can visualize treating what you can see as combining a CT scanner with a radiation unit, and that can be done. I mean,
in real time?
In real time.
Yes.
Real time. So 1 minute you're scanning the prostate, for example, and then you're treating it, then you're scanning it and treating it, and that can be done. I'm sure that will develop, and it will also further develop with respect to the head and neck and the brain. So I'm interested in that area. The other area that I'm interested in is in immunotherapy. I've been introduced to that by Dr. Hunter Sheldon over at the Huntington Medical Research Institute and Dr. Skip Jacquemus. And we're getting quite nice results in terms of prolonged life in patients who have malignant gliomas. Now, we don't have any cures, but we have patients who are living 5 years after the implantation of the lac cells into the tumor bed. And this is quite a bit better than some other techniques. And I think this is going to be a big future in neurosurgery, is the immunological aspect of brain tumors. And the third area is neurotransplantology. And this is fascinating. And the reason it's fascinating is because we sort of stumbled across the fact that you can take fetal neurons, pig neurons or rat neurons, or human neurons for that matter, and you can, under the influence of a new laser developed by the California Institute of Technology, you can cause them to proliferate. Yeah. And it's alarming to see them proliferate. It's really good news, because if you can do this and get a large culture of neurons, then you can inject the neurons and you don't have to go back necessarily to the source
yes.
of the human fetus, for example. I mean, you can continue the growth, and this is a very exciting area.
This is something that you're working on at the moment?
Yes, with a Russian who's come over from Kiev, and with Skip Jacquemus.
Where do you think the practice of neurosurgery is headed as you see it? I mean, the overall impression one has is that it's more difficult to practice neurosurgery today than it was in 1950, 51 when you started. Do you see any trends, any projections as to what the future might hold?
I think it's alarming. I mean, I'm alarmed about the way it is going. I mean, I grew up in a time when there was a lot of freedom in the practice of neurosurgery, as you know from some of the experimental work I did in the early days. But I think it's alarming to have so much restriction. I mean, the animal rights people, for example, are preventing, to a great extent, will prevent research in that area. And I think that's a terrible thing, because you cannot advance the science of neurosurgery without some basic research.
Do you think that this will alter America's leadership role in science?
Oh, I think so. I think it's happened in the computer industry. It's happened, or the electronic industry, and I think it'll happen in medicine. As long as these other countries will allow physicians, competent physicians and surgeons, to do what you and I used to do here in the United States, to try and develop, well, newer ideas. I mean, can you imagine today doing an anterior interbody disc removal and fusion? I think it'd be very difficult to start
a new program of that
type. It'd be difficult to get through the internal review board, because they'd be inclined to stay with the old ways, and not, even if the new way offered a better opportunity to the patient, they would be afraid to let you do that. And I think this is very discouraging.
So would you think that in the future the developments will take place in other parts of the world?
I think definitely.
With American surgeons traveling, perhaps?
Absolutely.
Have you done any surgery abroad?
Yes, I've done some in Mexico, some in Spain. And I think in Mexico, for example, with people like down there who are working, I think they will allow you to do more things under control, but more things than you can do in the United States. Of course, I don't speak very good Spanish.
Have your interpreters on
Right.
site, yes.
Right.
Well, I think this has given us a nice overview. Do you have any sort of concluding thoughts that you might want to tell us about your career in neurosurgery?
Well, I still consider myself like Dr. Collar. I think all neurosurgeons should consider themselves first a physician, then a surgeon, then a neurosurgeon, because they may get a very bright idea of how to treat some other disease. I mean, I'm still struggling with trying to convince the general surgeons that cryolumpectomy is a better way of doing a lumpectomy than the standard method they're using now. And I think one has to keep persevering in those other areas if you think you have something to offer.
That's right. You also worked with renal cancers.
Renal cancer. And I think you just have to, you cannot accept your current results as the best results. I was told by a famous surgeon when I suggested freezing the thyroid nodule so that you would avoid spreading the cancer, that, quote, the results are good enough. And I don't think our results are good enough. I think we can always improve. And the disc operations that are changing, you know, with the percutaneous ways, I think there's going to be a way sometime to do percutaneous fusions.
Yes, I suspect you're probably right.
And
So
I think that those things should be pursued, but it's going to be very difficult to pursue them in the United States.
But as far as you are concerned, and as far as your advice is concerned, you should always have an open mind.
I will pursue them wherever it takes me.
Okay.
Whether it's in Mexico or Canada or wherever I need to go to get something done that I think will serve the patient.
Great. Well, Bob, thank you very much.
Well, thank
it was
you.
fun talking with you.
Enjoyed it.
Goodbye.